hepatitis C treatment programme was a big part of my life for a long time. I worked in that area for many, many years, so delighted to come and talk to you about some of the work that we did in relation to access to drugs for patients. I'll just say to you as well, just in relation to Aoife, I met Aoife about a year and a half ago. A bunch of us in the HSE are undertaking a leadership qualification at the moment, and Aoife was one of the first people that the HSE brought in to speak to us. I suppose just to really reinforce to us the importance of putting the patient in the middle of everything that we do up front and centre. That's always been a big part of any of the roles that I've been involved in the HSE. So I'm delighted to see Aoife here today speaking to you. She's an amazing advocate and spoke to us very honestly to remind us in our leadership journey that the one thing that we have to remember is always to put the patient first. So just to acknowledge that to you as well. So anyway, we crack on with, we have about 10 minutes, so hopefully I'll be able to get through all of this in that time. Okay, so I suppose just in relation to the Hep C treatment programme, many of you will know that back in 2012 to 2014 there were some pretty transformative changes in the treatments that we were able to access for patients, or should I say treatments that were available at that time for treating people with hepatitis C. So I suppose basically we moved from an era of pretty horrific treatments that weren't that successful, but we were using them over a number of years with pretty poor outcomes, quite tough treatment, and I suppose that the transformation came around that time to an oral-based interferon-free rather treatment. So I suppose how were we able to get that into our health system? I suppose obviously there were barriers that we encounter every single day in the health services, and the first one up there is of course the cost of the treatments. At that time, the estimate of the number of people in Ireland with hepatitis C was somewhere between 20 and 30,000. Actually, it was somewhere between 20 and 50,000, but I think we can more accurately say with further data that it was between 20 and 30,000 people. We didn't have a national approach to hepatitis C treatment. There was no national programme. The policy that we had at the time was pretty much non-existent, and a strategy, an updated strategy on our approach to hepatitis C management was badly needed. So I suppose the simple maths at the time, back in 2014, was if we were to treat all of the patients that we have in Ireland with this new set of drugs that we had, it would cost almost €3 billion. So we didn't have, obviously, the money to do that. So what did we do? So compelling cases is what I would say were made to government at the time. I will say that the clinicians and the people who work in our health services, including the advocacy groups, would have worked very hard and lobbied very strongly to the government to allow access to these new drugs for patients. I suppose to balance that, I would say the suppliers of drugs into Ireland, of which there were 3 or 4 main suppliers at the time, would have lobbied very strongly into government as well. So I suppose the Taoiseach and the Minister for Health at the time, who's now our Taoiseach, would have taken a very big interest in hepatitis C, and so we were asked to look at the feasibility of a multi-annual hepatitis C treatment programme over a number of years with a view to establishing a national Hep C treatment programme. So a group of us got together under the guidance of the Department of Health's Chief Medical Officer, and we produced a report in 2014 rather, which basically said, yes, Ireland can establish a national hepatitis C treatment programme. It is feasible, despite the cost of the drugs, to bring about a multi-annual treatment plan to eradicate hepatitis C. And what they recommended was that the HSE would establish a national Hep C treatment programme and would develop a set of treatment criteria and work hard on procurement of the drugs in order to bring the costs in line with other countries and to allow us to treat everybody. So the programme was established in 2015. That was the vision that the programme set itself at the time. That is still the vision of the programme. So the programme is aimed to treat everybody across all treatment settings so that we make hepatitis C a rare disease in Ireland. So at the time in 2015, which is 4 years ago, it was around about €90,000 for a course of treatment for a patient over 12 weeks, and that was provided the patient was successfully treated in 12 weeks. A lot of patients required 24 weeks of treatment, and that obviously doubled the cost. The government capped the budget for the Hep C treatment programme at €30 million per annum, so we weren't allowed to spend a penny above that. So, you know, again, simple maths, €30 million in 2015 was only going to allow us to treat less than 350 patients, provided all of them were treated within the 12-week time frame. So it was a big challenge. It meant that we had to essentially ration the drugs. So we had a lot of criticism at the time. I think we made the front page of the Irish Times for about 4 or 5 days, where we were basically asking people to get sicker before they could get better, and that was the criticism that was levelled at us. But I suppose that was the challenge that we had. The cost of the drugs was so expensive at the time, we could only treat the sickest patients. So what did we do? I suppose one complexity that was there at the time, the government had signed an agreement with certain suppliers of drugs into Ireland to bring about a kind of across-the-board reduction in the cost of treatment, the EFA agreement that some of you might know about. So I suppose we couldn't go straight out and tender for drugs. That would have been, I suppose, in direct conflict with the EFA agreement that had been signed. So what did we do? So one of the big work streams that the programme set itself a target of was to reduce the cost, to put procurement up front and centre, with setting all of the other parts of the programme up and all of the governance structures that we needed to support the programme. So clinical leadership, advocacy, and a good programme strategy was developed very quickly within the first 6 months or so of the programme. We invited all of the suppliers, of which there were about 6 at the time. 4 of them were supplying the directly acting antivirals into Ireland. And we basically asked them a very simple question, and the question was, you can do better, and you can do much better, and we have 30,000 patients that we wish to treat, and some of the patients were sitting at the table with us. And I guess we sent all of the suppliers off with a message that they needed to do better and come back with a better pricing structure for the drugs. So in fairness to them, they did that. There were lots of caveats, needless to say, to them coming back with a slightly improved offer on the cost of the drugs, and that was that we had to tie ourselves into volume. So the programme tied itself into a volume, so we committed to a minimum number of patients that we would treat, and that was a right decision for us to make at the time. It was really complex. There were lots of suppliers with different products, essentially all doing the same thing. Different prices per genotype, and I mean, I thought that was grossly unfair to patients. Patients generally, in my experience with hepatitis C, might not be fully aware of the genotype that they have of hepatitis C, yet we were paying more for certain genotypes than others. So I suppose ultimately the programme ran into a difficulty in 2017, not just solely because of that, there were other factors as well, but the programme had to take a pause halfway through 2017 because we were running out of budget. And that was a really difficult position for the programme to be in. We did treat more patients that year, and I'll show you some of the figures in just a second. When the programme began to treat patients again, we went full public tender. We decided to go gung-ho with suppliers and pit, I suppose, each of the suppliers against each other in a competitive process. We didn't link it to volume, we didn't link it to minimum numbers. We literally just went out and we said whoever comes with the best price, and the clinicians were all in agreement that whatever drug offered the best value is the drug that they wanted for their patients. And I suppose that's what we did. It's a lot more complex than that, and in the time that we have now I can't really get into all the details, but I'm happy to take questions when we get to that. I cannot overemphasise how important and how, I suppose, constructive the engagement we had with suppliers at that time was. A really strong team of procurement specialists, the programme leadership and the patient advocacy, I think, was really the winning team that managed to get the cost of the drugs within the same price bands as some of our other neighbours across Europe were getting as well, without having to commit to volume. Finding out the cost of other countries and what they were spending and how much they were being charged for the drugs was a big challenge, because I suppose part of the deals that we've struck were that we are tied into commercial and confidence agreements with suppliers, and that creates a lot of work for us in the agency. We have to set up teams to collect rebates from companies and to track usage, and rebate is linked to really fine details that we collect in order to supply back to suppliers. But it's hard work that pays off because we were able to treat more patients. The outcome of all of that for us was that we were able to get better commercial terms and a better deal for patients, and we were able to lift the restrictions. So back to when the programme started, when we were basically treating only the really sick patients, and other patients who'd waited years for treatment and minded themselves and had waited so long weren't able to access it, we were able to lift up all of those restrictions. So this is just the very last thing I want to show you. So I suppose since 2015, over 4,000 of our population have completed successful treatment for their hepatitis C. And you can see each year we've been able to treat progressively more patients. I believe this year we'll see approximately 2,000 patients completing hepatitis C treatment, all within the 30 million budget. So we haven't received a penny more in funding for each of those years, and we've managed to do more with it each year. Hepatitis C is now eradicated in the haemophilia community in Ireland. Tomorrow's World Haemophilia Day, for people who don't know, and I think Ireland has been one of the first countries in the world to eliminate hepatitis C from its population. By the end of 2017, all of our patients infected through blood and blood products in Ireland had been offered treatment as a result of the hepatitis C treatment programme. And the rate of viral clearance, the most important message I suppose, is that over 95% of patients are now are now receiving a cure for hepatitis C when they go on this treatment. So what's next? Well, obviously we need to ensure that we continue to get the best value we can get on drugs, in line, if not better, with other countries. Shorter durations of treatment, so a lot of our patients are getting 8 weeks of treatment, and that should mean that more patients have access to treatment. That doesn't mean that we should be paying more if we have more patients. We should be paying less and less, and more patients should have access to treatment. Therefore, our procurement strategies need to change. So at the moment we're locked into contracts that we're pretty happy with, but we can do better. We can always do better, and our procurement strategies need to be kept under constant review. Drugs are changing, and the patient population is changing, and the way in which we're providing treatment is changing, and where we're providing treatment is changing. A lot of our patients don't go to hospital for their treatment anymore. They're treated within their drug treatment clinics and by their GP in the community, which is just really good progress for Hep C treatment. And my last point, which is the point that I started off with, the power of patient advocates. I think the work that Access to Medicines does, and all of the other advocacy groups who work with lots of groups of patients who are inclusive of the hepatitis C advocacy groups, do amazing work. And you know, I in the role that I'm in now, for example, right back into the front of you know, dealing with patients who are really kind of suffering at the hands of the health system. So I suppose I can't overemphasise the power of those patient advocates in all of the work that we do. So happy to take questions when we go on to the panel, and thank you for your attention. So main take-home messages for me today are that we have to continually work with our patient advocates in relation to bringing the cost of drugs into a reasonable space. I suppose my big interest has been in the National Hepatitis C Treatment Programme, and of course when the programme was established in 2015 the cost of the drugs were absolutely astronomical, so one of the first pieces of work we had to do was to bring the cost of the drugs in line so that more patients could access treatment. Today is all about how we can do things better for making treatment available and making it more accessible for patients, and all of the innovative ways that we've heard today in relation to how we can do that are really important. But for me, I think working with patients, I think thinking more innovatively, advocating and lobbying the political system as well, because I think our experience has been that once we've had the political support and the interest in the National Hepatitis C Treatment Programme, it has opened lots of doors and opportunities for us to bring treatment to people. So I'm here today to share the learning that we've had in establishing the National Hep C Treatment Programme. We have learnt, I suppose, quite a bit from engaging with the pharmaceutical industry, working with patients. I suppose the importance of having a programmatic approach that's clinically led. I think if everybody kind of works together, ultimately the result of that will be that we improve the access to really important drugs for our patients. I think obviously, you know, there's lots of learning, and everybody has new and novel ways of how we can, I suppose, improve accessibility to drugs for patients. I think every year there are developments. I mean, for example, 4 or 5 years ago, the National Hepatitis C Treatment Programme was starting with phenomenally expensive drugs with a population of 30,000 people to treat, and in 4 years we've managed to bring the cost of the drugs right down. I think we've managed to treat 4,000 of those patients, eliminate hepatitis C amongst the haemophilia community in the space of 4 short years. So I think from year to year the improvements that have been made, the experiences and the lessons that have been learned, I think in a year's time lots of other parts of the organisation may come back with further learning and further experiences they can share with all of the people that are here today.
Perfect.